AI in healthcare. Welcome, Vikram. So, healthcare is your favorite, AI is my favorite, right? So, let's roll. Now, the challenge that we have is we are very fragmented.
Healthcare is slow to adopt and fast to punish. There are a lot of areas where AI can play a significant role. From a hospital management process itself, lowest hanging fruit is things like operational. We have a problem where the doctor in India gets about 5 minutes with the patient, and in that 5 minutes, he has to write the prescription also.
Yeah.
So, can that be automated? Why not?
We are going to talk about India's perspective, India's context in terms of AI in healthcare. Now, the challenge that we have is we are very fragmented, and there is a lot of regulatory caution. So, although of late the regulation has relaxed a little bit, and there have been a lot of innovation that have also we've started seeing, even in the AI space as well, but not as much as we would like, given the opportunities that the fragmentation and complexity that India provides, and the opportunities also exist because of the fragmentation, because we have a large population. Underserving is in multiple ways. One is access, and the second is quality of care. About 70% of an estimated 70%, 60 to 70% of Indian population do not have quality care, and a large percentage also do not have proper access to healthcare. And when we talk about access to healthcare, it can be economic and it can be actual availability of healthcare. Given that complexity, AI can bring in a lot of standardization in terms of quality as well as access.
Correct.
Right? So let's understand from you as to what your views are to take us forward from here.
So, see, the way I define healthcare in the technology terms is healthcare as an industry is slow to adopt and fast to punish. That is the underlying philosophy of the industry. And this has been true of any new thing that has to be adopted by the industry. Where there were stethoscopes, which they took a long time to adapt. For a long time, people and doctors especially did not understand the importance of washing hands while attending to patients. So this is, as an industry, new, whether it's a new process, whether it's new technology, we take a long time to adopt it, and we are fast to punish if the adoption goes wrong. And there are enough cautionary tales in the healthcare industry when it comes to AI. And we can discuss that during the course of this discussion. But in India, healthcare is a high harm, and high variability industry. When I say high harm, it is a small change in something, a misdiagnosis can create a lot of harm to the patient or the individual, and high degree of variability. By doing some set of activities, I might not get as much affected as you are. It's because the way we are different with terms of our genes, genotype, phenotype, etc. So one of the biggest concerns that a lot of my peers have told me in the healthcare industry, and this has mostly come from doctors, is they are very afraid of misdiagnosis as a risk. So if you look at the differential diagnosis of a common headache, there might be around 100 to 200 reasons why headache happens. It could be something as basic as toothache.
Absolutely.
To something very serious as, say, meningitis.
Absolutely.
Both cause headache as one of the symptoms.
Yeah.
And that is why the misdiagnosis and patient safety concerns have been there throughout when it comes to AI. Second, in India, we don't have too many standardized data sets. That's primarily because A, we've been mostly paper driven. Two, we have not recorded a lot of our clinical research very clearly. When we do clinical research, we should have a clear hypothesis as to what we are doing, what are the steps we follow, and what was our end outcome. So what we end up doing is the data sets are mostly based on other studies done in other countries, and which leads to an unpredictable model behavior when it comes to Indian patients. Third, And this is a common problem, and this exists even in cases like remote patient monitoring, which is a no-brainer. But always the issue comes, who has the liability here? Remember, this is a serious industry where there's liability if something happens to the patient.
Absolutely.
So then who will face the liability if the AI misdiagnosis? Is it the doctor? Is it the vendor or the product company that built the AI? Is it the hospital? Who will bear the liability of a case gone wrong? And quite frankly, a lot of the algorithms even for me, are black boxes. We don't know why they do what they do, and I understand a lot of it is proprietary. That's why the product companies will not disclose what was the test data set, training data set.
Yeah.
How did they build the algorithm? That's proprietary. That's IP protected, and that black box, the mentality, the thought of that black box itself is scary for a lot of healthcare folks. Last but not the least, healthcare in India, and this is a very unique thing which exists. It exists in a lot of countries, but in India it's become very complicated, is that healthcare is a state subject as well as a central subject. So if you'll commonly hear things like Ayushman Bharat scheme is not being accepted by the state. Your home state is one of them, which created a lot of noise about it, West Bengal. When something is a state and a center subject, what is the regulatory oversight for it? Should it be state looking at it? Should it be center looking at it? Can we centralize it? Those are great thoughts. And, after so many days, so many months, so many years, last couple of weeks, CDSCO came up with regulatory norms for software as a medical device. Software as a medical device has been operating in India for about 10 years now. Just now we've come up with some regulatory guidance for it. What is CDSCO's regulatory guidance for AI? We don't know as yet. At least I'm not aware of if there is clear regulatory guidance for it. So because of this, the concerns are there. These are concerns, right? Now, why is the penetration low? Of course, digital maturity overall is very low. HIS is fragmented, PACs are fragmented. A lot of them are not protected. They have not been upgraded. There are security concerns, cybersecurity concerns with those applications. Number two, I think our legal system is also broken. And you might be wondering, what has legal system got to do with AI and its adoption in hospitals? It's because we don't want to, at least the hospital administrators don't want to go into a litigation of environment like US or Europe, where cases do come up and they do go to court and they get resolved very fast. Here, the cases can take forever. So why create another avenue where you could be sued? And the last, I think overall our policymakers have been fairly conservative, where they look at stability, patient safety over speed. So speed, this is slow to adopt, fast to punish, and the policymakers are also thinking on the same lines because we are conservative by nature. So these are the broad classification as to why this has been so slow.
Right. Now, in terms of AI adoption, one aspect which is very, very critical, which is the data itself, right? So what are the challenges do you think that the Indian healthcare industry is facing in terms of the data quality, the data infrastructure, and the data interoperability?
Right. So 70%, and I'm being very, very generous here, 70% of India is on paper. All the prescriptions I signed from the year 1999 to 2005 were on paper. None of them were ever digitized. I don't know if they're digitized today to the extent they are, right?
Not everywhere.
Not everywhere.
At least in metro cities, there are hospitals where they are digitized, but patient gets a handwritten copy in most of the places.
And nobody understands what's written on them, but that's a different story.
Absolutely.
Right?
That requires a different kind of AI for deciphering that.
Yeah, OCRs. So the underlying clinical data and the data models are weak. That is given. The laboratory information systems, which is the LIS, the health information systems, HIS, the picture archival system, which is PACS, radiology information system, RIS, they never speak to each other. They are all in silos. And there are a lot of hospitals, the top corporate hospitals have spent a lot of money in integrating them. But if you look at the Indian hospital scenario, only 13% of Indian hospitals are run by the corporate hospitals. With 87% of them are outside these big names that we always talk about. On the side note, I always have this joke when I read articles that Indian healthcare is run by PE firms. That is 13% of Indian healthcare, that too private Indian healthcare, that too private Indian hospitals. So 87% of Indian hospitals in the private sector are not run by PE firms. They are run by doctors who maybe, create 10 beds, 15 bed, 20 bed. That is a scenario.
Bootstrapped.
All of them have not adopted on technology.
Yeah.
So they are way out of the system. Also, there is this, the coding standards. When you code data in healthcare, you have to code them according to certain standards. The most common is SNOMED CT, which is fairly popular. The LOINC code, LONIC codes, that is another way of coding it. That's called Logical Observation Identifiers, Names and Codes. And there's ICD, International Classification of Diseases 10. That is the standard we are on. Now, these are the coding standards. Nobody writes an electronic medical record that Vikram has fever. The fever has a code. It is written with that code so that there's no confusion as to what is this fever. Because fever can vary from country to country and place to place. Now our adoption of coding standards is very, very poor. My joke is that the only people who understand the coding standards, especially ICD-10, are the insurers. They are very particular about it, and every health insurance company has experts on ICD-10. But no hospital does that. Hospitals will not invest in such people. So your data is not coded. That is another challenge. Metadata capture is very poor. Timestamps, fever at what time, fever came down at what time. It's very important. The time period it took for the fever to come from say 101 to 99. Your provider IDs, which hospital, which doctor looked at it at that time. That metadata is very critical because otherwise, how are you doing clinical research? How are you going to train the algorithm that this is what it takes or this is the time that the fever should come down after administering, say, XYZ drug? Then there is, the interoperability we have probably touched upon lightly, but except ABDM, where ABDM payments are required, where interoperability is slightly higher, it is fairly low. And the Ayushman Bharat Digital Mission has given an architecture of how interoperability should work. Adoption is on the lower side, right? Then, of course, there is no healthcare interoperability resources. And last but not the least, all the systems are siloed. So the lab system is not speaking to the hospital system, which is not talking to the insurers. So this is a much bigger problem. So I'll tell you, our problem is not technology. Technology, we're good. A lot of this technology is being made in India. Our problem is data and interoperability. Until we don't kind of handle this, then AI remains theoretically on paper a very good idea, which has very practical application right now.
Absolutely. So, all these points that you have mentioned, especially this coding, the medical coding, it sounded interesting to me. Unless your data, patient records are coded properly using the same standard, there is no point applying AI on that, because AI is going to expect a standardized way of coding, standardized labels. That's one of the cornerstones. One of the prerequisites of creating any AI model.
Correct.
And if that is not there, then it's simply not going to work.
Absolutely.
So it's a severe data adequacy, and then the only folks who can take action on that is going to be the hospitals, unless they spend enough money and effort on standardizing the data infrastructure within their hospitals. That is not going to, AI is not going to work out for those entities.
Correct. And quite frankly, they are not able to justify the ROI also. See, at the end of the day, it's a business. And I respect every doctor who set up his own clinic because he has taken a risk.
Yep.
He could have taken the easy way out. He has taken a risk and we have to respect him for that. But A country which has no social security, where you're on your own, he is well within his rights to look at an ROI. And the ROI just isn't there to do all this so that he can use AI. Unless a clear ROI emerges, it will be very difficult. You can always see, you can hire somebody and do manual coding, manually do things.
Yes, absolutely. But is it also not the case of having foresight about that ROI and awareness about that ROI? Because see, if you invest in your data quality, data standardization, data availability, and data integration, right? So that AI-based automation, AI-based smart decisioning strategy, etc., are possible. If that awareness is not there within the doctors, it's never going to happen, because you only have so many um, top-notch hospital, large-scale hospital chains, right? And if the next layer is not educated on creating their data infrastructure, data standardization, this is not going to happen.
Yeah, so for that you have to look at a typical, costs involved in building a hospital. The largest cost is land.
Yeah.
Real estate, which is your largest cost. Then the interiors, because there are certain specifications under which the hospital has to be built.
Devices.
Then comes devices, which is the third largest cost. Then is OPEX, which is the staff salaries. Then comes the clearances, all the NABH, accreditation, pollution, power, environmental, biomedical waste, right?
Waste management.
Then you have hygiene factors, whether there is services, what kind of services, setting up labs, setting up pharma. Then comes your technology.
Yeah.
So
by the time you are already exhausted.
By the time you come to technology, and I'm not kidding, I built a list of, and I'm simplifying this. I built a list of things we need to do for a dental clinic because we want to go about it scientifically.
Yeah.
And some of us were like working on it. Right. This is as recent as last month. Technology was at the 13th position, right? So by the time I've gone to technology, I have exhausted all the money I have and I have nothing left.
Yeah, absolutely. Absolutely.
So how are we going to, first of all, I have 3 routes to investment. Yeah. Either I fund it with cash. Nobody does that. Second, I take debt. Third, I take equity. That's why I've been one of those people who's been very positive about PE firms coming into corporate hospitals, because eventually the PE firms will look at areas of improvement. And one of the areas of improvement clearly is what we're discussing right now. And if anybody's going to adopt AI faster, it's going to be the corporate chains backed by PE firms who are ready to invest in this area so that the ROI comes up in 5 years. No bank or nobody is going to self-fund this. If you ask the bank that I need loan because I need to build an AI system that will make my hospital work, I don't know how many banks will give such kind of a debt.
You'll get a look.
So it's a case of healthcare financing. Yeah. It's also taking a long-term view. But let's not forget, even if the corporate hospitals do it, Manas, it's only 13% of healthcare.
That is a sizable number. I would have thought that it's a much lesser percentage.
13% is what we have calculated are corporate hospitals of private healthcare institutions. So I think the financial model doesn't work. Even if at our heart and philosophy we think that this should work, the financial model doesn't work. And there are a lot of ways we can learn from other industries, right? Like what we can learn from defense. Defense was going through almost a similar thing. All equipment was imported. Look at today, we are indigenized, not everything, but significant portions of it. There are startups. Space is another one. So when we can do it in defense space, healthcare seems a no-brainer.
Absolutely. The demand is much more. The entire population is your market.
Correct.
Right, absolutely.
And let's not forget exports.
Yes.
8 to 11% of our corporate hospitals' revenue come from international patients. Yes. So the whole world is available.
You can create a few unicorns even before you can you think of exports in
That's
healthcare.
That's a great business idea, right? You can actually do that.
Absolutely.
Yeah.
So, given all this, what do you think are the 2 or 3 low-hanging fruits of AI adoption in the healthcare industry?
Yeah. So I think we discussed this earlier. I think we have to, first of all, let's leave the clinical portions alone for now.
Mm-hmm.
Because when we immediately look at healthcare and you say immediately, can we do diagnosis with AI? I think that is going to take some time. It requires a certain degree of maturity, both from human capital as well as for processes. But there are a lot of areas where AI can play a significant role. Now, the role of the hospital is to treat the patient. So, any money you can save or manpower you can save that are directed at non clinical processes that can be redirected at clinical processes is a big win for a hospital. They need more money for research, they need more money for surgeries, they need more money to bring in the right kind of people. So, I think from a hospital management process itself, the lowest hanging fruit is things like operational AI, bed occupancy, rotation of beds, bed efficiency, forecasting,
Inventory forecasting,
inventory forecasting,
yeah.
OPD flow,
even
is
medicine inventory forecasting,
medicine management.
Yeah.
So OPD flow today is the biggest cause of patient unhappiness or lower patient experience. OPD takes so long, registration takes so long. That can be really fast tracked with AI. Doesn't require too much critical data, does not require diagnosis. It is a pure queuing problem.
Even discharge.
Discharge is another ball game altogether, and I'll talk to it. Second is the diagnostic triage. Now, this is where you see most healthcare startups operating, which is your radiology, pathology, where you do diagnostics. You have blood diagnostics, serology. Now, this is a clear area that already a lot of work is happening, just X-ray screening and stuff like that. Now, the administrative automation, this is what you talked about, claim adjudication, account receivables, account payables, things like medical coding automation, the codes that we discussed, ICD-10, etc., SNOMED CT, they can be automated using AI.
Very easily.
Right? You don't need to diagnose. But
now with generative AI, you can work
you can transcribe
around
all that, right? Clinical documentation.
Yeah.
So we have a problem where the doctor in India, there's a common number that Indian doctor gets about 5 minutes with the patient. And in that 5 minutes, he has to write the prescription also. Yeah. So can that be automated? Why not?
Absolutely. With generative AI, it's going to be very, very easy.
Then to the point you made on discharge. Now, what is the biggest cause for nuisance around discharge? Discharge, I've spoken to enough people on it. Practically, theoretically, discharge cannot be reduced beyond 3 hours. Do you know that in India? You can't have, even theoretically, the process itself takes 3 hours. But in reality, discharge takes anywhere between 8 to 12 hours. And a lot of it is to do with documentation.
Yes.
And the codes, which we talked about, and the discussion between the insurer and the provider.
Yeah.
So all that it is non-clinical because this has got nothing to do with the patient diagnosis and treatment.
Absolutely.
But it has a huge role to play in reducing the OPEX of the hospital.
Yeah.
And you can justify ROI. And the money you save from all this and the maturity you gain, both in terms of people, technology, process, you can direct it towards diagnosis. But if you start with diagnosis and say, I'm going to diagnose using AI, it's a non-starter because you will not be able to justify the ROI.
Yeah, right. So even the discharge process, I mean, if you are holding up the bait for 8 hours, that's the bait lost for you.
Correct.
For half a day, almost half a day.
Correct.
Right. So these are cases where we get huge opportunities, operational opportunities.
Correct. See, the average length of stay, ideally, hospitals have done a great job of bringing it down to 3.4 to 4.4 days. Looking at a bed occupancy of 70%.
Right.
I think AI can reduce it further.
Right. Absolutely.
And that is cost saving. That is money in the bank for the hospital. Because the
For
patient is really not doing anything except occupying the bed.
Yes.
And remember, this is not like a hotel bed, right? So once the patient goes, it has to be cleaned, it has to be cleansed, it has to be fumigated so that the next patient occupying doesn't get infected.
Absolutely.
So there is turnover time. So I think that's a big use case that they can use.
Absolutely. So going to another world probably, I mean, Here we are probably taking a perceived case of a corporate hospital or a large hospital in a metropolis city or something like that. But then going to the underserved part of our world, in our country, um, the standardization of quality of patient care. I mean, what kind of opportunities do you think in terms of triaging, in terms of diagnostic, etc.?
See, I think personally, if you ask me, is a AI system better than no doctor?
Absolutely, that's a
Definitely,
great point.
AI system is better. I
Yeah.
have something that tells me that this is happening. So if you look at beds per population, India has, I think, 1.3 to 1.4. But in cities like Bangalore, it's 5. Global average is 3. So you're 1.3 to 5. That means there's overcapacity in the cities, right? Hyderabad, Bangalore, Chennai, Mumbai, Pune, Delhi, Kolkata. Those are the ways where the capacity is high. What happens to those who are outside this capacity? They are left at the mercy of the CHC, PHC, or whoever is available there. Now, your simple thing like not diagnosis, because when I say diagnosis, it gets serious. I'll say triage protocols, symptom clustering, vital sign checking. I think AI can do that. And I'll give you some more use cases. Very basic primary diagnostic. Just like how you run a diagnostic on your computer. Something like that.
Absolutely.
That AI can run.
Yeah.
Because remember, if this patient has to go for medical treatment, that patient has to travel 30-40 kilometers.
Yeah.
If you go outside Bangalore, you'll face the same problem. You go to places like Bidar, or you go to places like Golconda.
Yeah.
You go to, not Golconda, sorry, Gulbarga. The availability of healthcare professionals is very poor.
Absolutely.
So
quality also.
Yeah. Then chronic disease management. Okay, I understand you don't want to do diagnosis, but a patient suffering from diabetes, suffering from blood pressure. I think it's a huge investment opportunity for startups. They're already doing it. They're doing a lot of work in this space.
Yeah.
But again, their focus is on the cities.
Right.
If you look at all the healthcare startups, and they're right, again, they have to survive too. But chronic disease management is a big area where if you can bring the costs low enough
for the patient.
Yes. They would be ready to subscribe. Yeah. And our telecom industry did that. Costs were so low that almost everybody has a phone. Almost 800 million have a smartphone, and so on and so forth.
So we do it using ChatGPT now.
Exactly.
Why not put a standardized mechanism around that?
Correct. Yeah. Then there is the entire augmentation of telemedicine. I'm not saying you do telemedicine. Augment it.
Yes.
Like you use a smartphone or use a normal phone. You're talking to a doctor somewhere else. Yeah. AI augments it, both in terms of scripts, maybe vernacular language, make the patient understand what's happening. Auto summarization. Yeah. What did the doctor say in that 5-minute discussion? What did he say? Yeah. What do I have to do? Things like your support. Can we order a set of medicines, or can the medicines be sent to a local chemist? Absolutely. So that he can send you the medicines? Yeah. Then, of course, one of the biggest use cases, and this is what I'm very proud of. And when we talk about AI, the way AI has helped us in our TB program, I think that's the first time that AI has joined is at the front. And because the government is so fixated on TB right now, and 24% of disease burden of TB is with India. Next highest is China with 8%. So the government has decided to eradicate TB by 2030, which is a very ambitious goal. And AI is right at the forefront of looking at X-rays, chest X-rays. Yeah. And so when that can be done, and it is just a decision whether the patient has to be seen by a pulmonologist or no. Yeah. That's it. It is not that the AI is giving any medicines. And the medicine protocol is fixed. For TB, the medicine protocol is fixed. What needs to be given, in how many doses, what medicines, and they are freely available in government dispensaries. So when we have achieved that in one disease, we can just increase it. And for a person living in a rural area, if there's no doctor, can he be made aware that he can use the system?
in primary care centers.
Primary care centers.
Government-run primary care centers.
Absolutely.
So if there is an initiative with startups or even corporates to create an infrastructure of higher quality primary care in government-run primary care centers, I don't know how many of them are in India. It's a massive, massive opportunity, and opportunity not only to monetize this, or also to raise the bar or raise the quality of primary care in those areas, towns and villages.
No, I agree with you. And I think there is some movement. Some of the primary care centers have been being run by private institutions now. The government has outsourced them. It's mostly happened in the south.
Okay.
But I think there is an opportunity here. And if the government is really serious about AI in healthcare, why not start with the PHCs? PHCs, not CHCs, even PHCs to begin with.
Yeah.
And see how it works in 5 or 6 conditions which are endemic to that region.
Absolutely. And those are high population, high percentage, right? I mean, how about just like we have telemedicine now on our smartphones, presence of smartphone may be scarce in villages. So why not a kiosk in a primary care center?
Maybe kiosk.
Yeah.
Maybe even a feature phone can at least get the end result of an AI.
Right. So the primary diagnosis, talking to the patient, is done by the kiosk automatically using AI. And then when there is a intervention required by a specialist or a doctor, then the triaging happens with the doctor.
Correct. Absolutely.
Yeah, I mean, I think there are a lot of use cases around this. All right, so going into another one, I mean, if we start journeys in different directions using AI in healthcare in India, there are also going to be other aspects that the regulators are going to be focused on: bias, misdiagnosis, and etc. So what your view is that what are the risks that we run in those areas?
See, first is your bias is coming from your data set itself.
Yeah.
Irrespective of what you do, even if I take India only data, your data set is going to be primarily urban and primarily metro.
Absolutely.
That is where your data is from.
Yeah.
And we all know that health problems in the metros are different from health problems in the rural areas.
Absolutely.
Second is your linguistic bias. As long as the data set is in English or some major language, it will be well understood.
Yeah.
We have 22 languages as per the schedule of the constitution, which are recognized in India, and I don't know how many dialects. So that is a very unique problem only to India. That is not prevalent in too many countries.
Right.
Third is your socioeconomic bias. If it's standardized data set, it will be from the upper echelons of society.
Yeah.
The lower strata of society is not captured.
Yeah.
Because they are using paper records or they have no records at all.
Yes.
Right? What about tribal populations? So I was talking to a doctor a few days ago, and he talked about sickle cell anemia, which is endemic to a set of tribals who live near Nandi Hills. It's called BR Hills.
All right.
Because they intermarry a lot. And intermarry among the same family quite a lot. And sickle cell anemia affects the males. And it is genetically transmitted. Some genes are... So if you have a dominant gene and 2 dominant genes come together, it represents itself.
All right. Okay.
So sickle cell anemia is a big issue. Now, this is in a rural population, which is a tribal population.
Yeah.
So that will not get captured in any of your data sets.
Absolutely. And then it may go drastically wrong.
Correct. Absolutely. Yeah. And there is also this risk of AI-driven misdiagnosis.
Yeah.
Which is there. And we have seen that like Babylon AI was one clear cautionary tale that everybody talks about, how it was misdiagnosing serious conditions like cancer and downgrading it to just fever. Now, there is also then the second set of bias is around accountability bias. And this is something we discussed briefly earlier, who's accountable for this. So is the clinician... See, in today's healthcare system, the way Indian Medical Association works, Medical Council of India works, the clinician is responsible for the patient. So the accountability lies with the clinician.
Yeah.
So with the AI coming in, is the clinician still responsible? Who's accountable now? And if he's going to be accountable, maybe he doesn't want to use it.
Right.
That is why a lot of hospitals, when they introduce AI, they said this will be a support. We used to use this lovely term, clinical decision support system. We still use it. It is a support system. Absolutely. It is not a decision maker. Yeah. So it is saying, maybe you should give Manas a paracetamol. That is my recommendation. We leave it to you.
Absolutely.
So yes.
Same as ChatGPT.
Like ChatGPT.
Yeah.
Right? Then most of AI systems are built by product companies. What is their accountability if something goes wrong?
Right. Absolutely.
Is OpenAI responsible or Alphabet responsible for Gemini? Yeah. Then, okay, if clinician is responsible for diagnosis and the vendor is responsible for the product, the hospital is responsible for the governance, infrastructure, storage. What is their accountability? And then finally, I don't know where the regulators fit in here. If CDSCO does not even have standards for AI,
right,
then we have a regulatory bias.
Yeah, absolutely.
So I think there is enough scope. I'm not saying we should not do it. I think we should do it. But we have to consider all these factors. And let's not forget, there should be some kind of representation of all strata of society. There should be explainability. What causes what? There should be auditability. I should be able to audit all this. How the AI has come up with this conclusion. And at the end, it should be locally validated. That means if the AI is giving decisions continuously, I will need a clinical validation to see locally, is it what it is or is it something else?
Absolutely.
I think there is enough scope for us to do it. And somewhere I feel DPDPA will trigger a whole wave of this, because hospitals would have gone through so much pain, or pharma companies and CDMOs would have gone through so much pain of complying with it. They will finally understand how much data they're sitting on.
Absolutely.
And that might trigger a whole wave of AI adoption.
Absolutely.
Saying, I have the data.
Yes.
I've spent too much time on this now. I'm going to build something that will use it.
I hope this awakening comes up.
Right.
Yeah.
It's like, it's always like my kids, they will not play with a toy for a while or something for a while. And suddenly I will say, hey, this has been lying here. What are you doing with this? Yeah. And after that, there'll be severe use of that product.
Yeah, absolutely.
That toy.
Rediscovery. Like new.
Yeah. I mean,
absolutely.
We are all clear that the data mapping exercise is going to be one pain.
Yeah.
But once you do it, you're thinking, why am I not using it?
It's a gold mine. In a lot of cases, it's a gold mine.
Yeah.
But then there is still going to be a lot of exercise. Even if we sort it out for DPDPA from the privacy angle, coherency of data, because Correct. You have different fragments, and then undertaking an initiative to make it coherent and ingestible by AI
Correct.
is going to be still to be done.
Correct.
Right. Okay, so then we come to adoption barriers.
Right.
So what in your mind are the real adoption barriers to AI related innovation? Would it be cost? Would it be workflow disruption because you have ways of working, and then introducing a new technology like AI is going to disrupt your workflows, new trainings, and people resistance, or clinician resistance, medico-legal risks, or lack of clear ROI?
So I think ROI is number one. And the ROI problem comes because of use case selection. I have told this again and again to a lot of my friends in healthcare. The biggest challenge that AI adoption in healthcare faces is all of what you said is true. And these are factors. But the biggest factor is use case selection itself. In management, forget hospitals, forget healthcare, any management scenario, if you pick up a use case, you will have to show what is the return on that investment, because somebody is investing on it.
Yeah.
If you are not able to justify the return on investment, it remains where it is. That means in a lab or in a sandbox. I think use case selection, which leading to a quantifiable ROI, is the biggest barrier. And healthcare organizations have fallen over themselves over this. Because, and I am very critical of them in this, what they've done is they have looking, it's almost become a copycat scenario or a Me Too scenario. there's FOMO, fear of missing out. They're doing AI, we should do something in AI. And AI gets you good press. And media is very intrigued. Oh, they're using an AI system. But do I need AI to sort, say, a queuing problem? A queuing problem, which is a very common problem all of us face in hospitals, can be solved by just looking at CCTV cameras and putting a rule.
Absolutely.
Right? Yeah. It can be done by, or passing out water bottles if too many people are standing in line. It does not require AI. It requires common sense and a little bit of technology.
Yeah.
So I think the use case selection leading to ROI is the biggest challenge. The second biggest challenge is a human capital challenge. The biggest problem healthcare in India face, and I say this across the board, including devices, is that we don't have the right people. We don't attract the best. When I was in B school, we used to have this joke that सबसे तेज दिमाग वाले तो साबुन तेल बेच रहे हैं. Matlab, FMCG used to get the best. And that was the reality. Then it became banks. Right. Banks used to get the best. Then it became investment banks. And today you have all the product companies who hire the best. They take the best. Now, whoever comes to healthcare, these are people who, despite everything, have gravitated towards healthcare. These were not the ones who chose healthcare as the number one profession. Right. So we just don't have the human capital. Even if you ask AI and you say, okay, let's do AI. How many ABDM architects do we have who can integrate the AI system as per ABDM standards? Just to begin with. I'm using ABDM as an example. Absolutely. Not too many. Not too many. They don't know what is to be done. US changed that because of Obamacare and a lot of digitization happened, and suddenly healthcare became a hot sector. But we have a human capital problem. Then, of course, there's cost. I'm not denying it. Like I told you, in the whole MIS that we were creating, this was coming at number 13 or 14. By the time all the money had been parked in various sectors. There is obviously huge resistance from my friends and my peers in the healthcare industry, the rock stars, the superstars of the industry, which is doctors, because they don't want clinical disruption. They don't want workflow disruption of their clinical workflows. They don't want that. And often these decisions are making, not keeping them in consultation. If you involve them, and there are a lot of doctors I know who've been deeply involved in technology programs, and those technology programs have been fairly successful. At least the resistance from the doctors has not been there. Even if the use case selection was wrong, the doctors went ahead with it. But without doctors' involvement, and you try to disrupt what they're doing, then it's a big problem. Last but not the least, we still have infrastructure gaps. It is filling up fairly fast. Tier 1, I think we don't have it anymore. But Tier 2 and Tier 3, there's huge infrastructure costs, bandwidth, network, availability of storage. It continues to be a problem. Power. You can't have regular power supply. Absolutely. So those are some of the initial challenges. And I think if you solve the ROI and the human capital problem, that's Pareto. That's 80% of your problem.
Right. Okay. So, I mean, with all these challenges that we are hearing, what can regulators do to ease the situation? Let's say, especially around approvals, sandbox, reimbursements, national standards, and etc.
So I think for AI, we have to clearly say, I think AI will be treated as software as a medical device. Right? I think that is where it will fall. We need that classification very clearly, or we should have a separate classification, say AI as a medical device, because software as a medical device, SAMD is fairly popular, but AI as a medical device is not. We should probably call it out. I think an AI validation framework will also go a long way. Is there a national benchmark of how the data model should look, how the algorithms have to be created, how they have to be coded, what should be the quality of data? We haven't done that as yet. I think there's a fair bit of time. I think we should do it because we are still in early days. We have not advanced a lot further. If we do it now, then the degree of standardization will be much higher. There is no way people get incentivized for using AI. What I'm saying is slightly controversial. I just told you that all those cost items went and then there was AI. What if the government paid hospitals to adopt AI and justified that cost take back through some other measures? There are ways to do it. I mean, I'm not putting words in anybody's mouth, but there are a lot of incentives that the government gives.
Yeah, absolutely.
You have PLI schemes, right? For example,
yeah.
for production linked incentive. Can we have an incentive to adopt AI in the hospital?
In terms of tax breaks and etc.
Tax, so the tax is one. I did one entire segment on GST and how it impacts. GST on medical devices is fairly high. GST on imports is high because we are importing medical devices. GST is on pharma. GST is on beds. But can we give some breaks to them?
Right.
At the state level or national level? Like Telangana, government of Telangana gives a lot of SOPs to hospitals. They also give a lot of SOPs to GCCs. Can we give them SOPs to adopt AI? I think it's a slightly controversial point because then we'll have a rush to AI. But can we have a framework and then tell them, okay, you adopt this framework and you do this and we will give you this much SOP.
Yeah.
It's an idea worth considering. The last area is, I think the government needs to slightly enforce the cybersecurity and privacy norms, which will be counterproductive to AI. I know if more you try this, more that will happen. But algorithmic risk is a very big risk. We don't know what's inside the algorithm.
Yeah.
Coders copy paste code to write algorithms. We don't know if a vulnerability is a Trojan has been embedded in the algorithm or not. And we'll find out much later. I think a little bit of scrutiny on that is important. But I think if they select the right use case, give them an opportunity to for human capital development, put classification AI as a medical device, give some SOPs, I think this will become the next powerhouse.
Absolutely. And if there are any AI riders to be added on top of DPDPA to regulate it, that's even fine.
Why not? It's in your hands. Now the DPDPA rules are just out.
If that promotes innovation.
Why not?
Yeah, absolutely.
Especially in rural areas. See, one thing they can do, government has a lot of data. I know census hasn't been done since 2011. 2021 census we had to forego because of COVID. And now the census is going to be taken.
Yeah.
Can we look at all the districts where a patient to doctor ratio is very, very poor? Can we push some AI intervention there?
Absolutely.
I'm just giving a thought because asking doctor to move to a rural area and work there from the goodness of his heart is not going to happen in this world.
A lot of upstream tasks in the primary care workflow can be taken up by AI.
Why not?
Kiosk and stuff similar to telemedicine.
Correct.
Yeah, and hand it off to a actual doctor whenever required. Otherwise, probably 80% of your 70-80% of your patients are having very common diseases, ailments.
See, I think the way to do it is, how you monitor a network. NOC, Network Operation Center.
Yeah.
You're not sitting at every node and watching the node.
Absolutely.
All the nodes are connected and you have a centralized scheme from which you're monitoring.
Yeah.
I think a similar one can be done for primary health centers.
Yeah.
You have AI kiosks.
And a central command center.
And central command center where a human being is looking through, where we always say, I always tell you this, and we had a good discussion about it the other day. In AI in healthcare has to be supervised learning.
Yeah.
It can't be unsupervised learning because we don't know what the AI is learning.
Right.
And there has to be a doctor in the middle. Why not create a command center? Let them monitor the primary health centers, the AI portion of it. Let them identify what disease patterns are emerging and where they need to focus.
Absolutely.
And the algorithm can be changed. So the advice can be given, changed on the season, weather patterns.
Yeah. And the individual case-to-case basis. I mean,
that intervention, you already have ASHA workers and all the Anganwadi workers. So where cases there where they have to intervene, they can intervene directly.
Right. Absolutely.
And you already have feet on the ground. That's
and
the beauty of our system.
Yeah. And if you have a kiosk-like things, that is going to be kind of supervised by this Anganwadi workers.
Absolutely.
Yeah. Absolutely. Cool. So if we try to figure out, look a little bit towards the future, what do you think the kind of innovation we can look at in the next 3 to 5 years in India?
Definitely hospital operations. I expect a lot more hospitals to become smart hospitals.
All right.
AI managing operations, less human judgment there, more streamlined strategic decision making. I definitely see in primary care what we just now discussed. I think it's a matter of time. Whether that kiosk is there in every PHC or everybody gets a phone. Now the government has mandated every smartphone has to come loaded with a security app.
A kiosk can also be a tab.
Absolutely. It could be a tab.
Yeah.
It could be a device.
Yes.
A phone. It could be
Absolutely.
anything. I do think chronic disease management is going to go into AI hands. Because when you look at a disease like diabetes, hypertension, chronic kidney failure, a 10-year period, 7-year period, I think AI will have a lot more role to play there. That's my strong belief. And the last but not the least, every public health program. TB is a great example. And what the government has done, Cure.ai is working with the government. And there are some other products which I don't recall right now. But it's a fantastic model of how you can screen a population of 1.4 billion. 24% disease burden of TB. 4 lakh people die of TB every year. And that is what the government is after. Because it's a big drain on the family. It's a socio-economic problem. What they've done with TB, it can really be extended. My fear is once TB, whenever we achieve this victory on TB, we will just wind up the program. But we should get the next disease sets in.
Absolutely.
And keep moving, because that way our AI program keeps maturing.
Yeah.
So I think the future of AI is that despite all this, it is here to stay. And now it's a question of where do we direct AI on?
Absolutely.
And finding the right use case, getting the right people to work on it will be the first step.
Excellent. Thank you, Vikram, for your wonderful insights about AI and the future of AI in India.
Thank you, Manas.
Thank you.